It's a real honour that I've been asked to speak to, an honour for me to be able to come today and speak to you all. I'm very nervous because I'm used to talking to and speaking to other healthcare professionals and other people who I work with, and I've never spoken to a group of patients, so I'm very nervous, so you have to be very kind to me. Of course, there's obviously room for questions, and if I don't know the answers, then I'm just going to be honest with you. I can look them up and get back to you via Deborah by the end of the day if there's anything that you specifically want to know about or ask about. I'm Sharmistha, and I work as a medical oncologist in Guy's Hospital in South East London. And I've been working there for 15 or so years. I treat patients who have lung cancer, and I specialise in treating ALK rearranged lung cancer and other cancers for patients who have probably never smoked, so other molecularly driven cancers. And also I treat patients who have gynae malignancies as well, so ovarian cancer, endometrial cancer. Okay, these are my disclosures. So Deborah asked me over the summer to speak today, and the title that she gave me, I think, is the hardest topic out of everybody this whole 3-day conference, What Next in ALK Lung Cancer? And the reason I think it's difficult isn't because I have nothing to talk about. I actually think I've got a lot to talk about. And I was thinking for the last few weeks and months about how I would put everything in a concise form to see if you all agreed and were enthusiastic about this as much as I am. I think we've actually come a long way. The thing about ALK lung cancer and other non-smoking related lung cancers is they're relatively new cancers. So when I was training as a doctor, even before an oncologist, so in medical school, and even during my medical training as a doctor, we weren't taught about ALK lung cancer. We weren't taught about EGFR lung cancer. We were taught about lung cancer, non-small cell lung cancer, small cell lung cancer. And that's the chemotherapy you give, and this is the side effects that patients may get. That's really what we were taught. And I'm not that old, so this is quite recent. But really things have changed a lot in the last 10, 15 years. We all got really excited in the world of oncology, kind of the late 2000s, just after 2000, that 2000 to 2010. And that's when we really started discovering that cancer is actually really a magnitude of different things, different molecules, different pathways. And now we're really working towards understanding the science, or trying to understand the science between cancer and how that applies to the clinical world. And our job, I feel, is to put one with the other and then see how far we can go and hopefully get better outcomes for our patients. So really things have really only been taken off with molecular, all the molecules, all the things we're doing in the labs since in that time. So let's say 15, 20 years. So I think we've come a long way, but I think there's a lot more we can do. We've created a drug, or many drugs, as you heard this morning, and you're going to hear later on today, to target this rearrangement, this molecule, this deficiency in this protein, the ALK protein rearrangement that's occurred. And that's all very well. We've created more than one drug. There's 2, 3, now 4th generation tyrosine kinase inhibitors. Those are the tablets that we're prescribing every day to our patients. But there's a lot more that we have to do to get things better. So I've decided to put the session into little sections. First of all, I'm going to talk about how we're improving perhaps the prevention of ALK rearranged lung cancer. Then we're going to talk about the diagnosis and how that can be improved, that pathway. Talk about the treatment itself. And then last but by no means least, the quality of life that we are living with in this community. So first of all, prevention. Screening is not really that helpful. We don't have a national screening program in the United Kingdom, as you know, for lung cancer. There are some trials and some studies going ahead in the Western world with looking at screening for lung cancer, but it's not that helpful for us. It's looking at patients who have either smoked very heavily or who are current smokers. Very encouraging, very useful. I think it's very important we do that. Patients are receiving low-dose CT scans, for example, to try and detect the early diagnosis of their lung cancer. But we're in a different boat, aren't we? We know that smoking isn't really a risk factor for ALK lung cancer. So we're stuck in a little bit, it's all very well doing the screening, but we need something else to look at and to analyze. Why is this cancer happening? Why are we all sitting here today? We know that ethnicity, the sex of a patient, their age, diet, there's not really anything really hard there that we can hit to try and target stopping that lung cancer from even developing. There's been a lot of notion and a lot of thought, and probably all of you will think, well, of course, air pollution, it's a no-brainer. Yes, of course that's linked to lung cancer. That must be one of the main reasons that we're meeting now and we're talking. But we have to try and prove it, don't we? We have to try and really get down to what in the pollution could be causing the lung cancer, or could be a risk factor. It might not be the only reason, but one of the reasons that this lung cancer could be developing. So this is a picture, and it's just been published in one of our scientific journals, The Lancet, only a few weeks ago. And as you can see, it's nasty, horrible air pollution. And this article was published simultaneously with a presentation of a really big study which was presented as a late-breaking abstract in our presidential symposium, so really hot off the press stuff, in one of our oncology conferences just at the beginning of September. The purpose of the study, I'll come back to that. The purpose of the study was to really understand the development and the link between pollution and cancer, lung cancer. Now, the study actually looked specifically at EGFR mutated lung cancer, which is a different type of lung cancer. We're talking today about ALK lung cancer, but they're not dissimilar in the fact that they are both not related to heavy smoking history. They're both molecularly driven cancers. So there's a mutation within the makeup of the cancer that's driving the cancer. So I'm using that as a benchmark. And actually within oncology itself, you'll see, and I'll speak about in the next half an hour or so, we have to use the work that we're using in other parts of oncology, other molecularly driven cancers, to try and encourage what we're doing specifically for our ALK lung cancers. So it's really important that we look at one thing, the number of patients. Another thing that we're really struggling with in ALK lung cancer is that it is a relatively rare lung cancer compared to the other types of lung cancers which are caused by smoking, or not the molecularly driven ones. So almost 500,000 individuals in this study, which for us is a really good number of patients. We're going to get so much data from this. We're going to be able to analyze a lot of things. So that's one thing that I think we're really, really enthusiastic about. Yes. So the summary of this study showed that there is a definite link between the pollution, and there's a specific particle called oh my goodness, what's it called? Some particle. I can look it up on my phone, and it's found in pollution, specifically in exhaust fumes and particulate matter. That's it, PM. So particulate matter is this little protein that's found in exhaust fumes. It's found in the smoke that we create when we burn fossil fuels. And there's been a definite link between this particulate matter and the development of cells growing EGFR, so this EGFR mutation. And it was found in cells in our airways of humans and in mice. So if we look at airway cells, and if you expose those cells to this particulate matter, which we know is found in the air, in polluted air, then the concentration of the EGFR mutation rises. And we know that EGFR mutations can cause lung cancer. So I think this is something that probably we knew about. Yeah, of course, air pollution causes lung cancer, but we have to demonstrate it. We have to really go back into the science, into the molecule, to try and work out what in the pollution is causing the cancer. And maybe we can go further now and try and stop that particulate matter from doing the stuff it's doing here, I don't know what yet, that's causing this EGFR mutated lung cancer. So I think that's really promising stuff in the science world, but also in how we're living. Hopefully we can now, in the general public, there's a lot going on about climate change. There's many reasons we need to improve how we use our energy. We have to look after the environment for our future generations, but we know we have evidence that it is causing cancer. So this is something that I think as a group and as a population, we owe it to ourselves to try and change things. So I think this is going to be something that we're going to be seeing coming up in the next few years. So, talked about prevention. Now about diagnosis. When we're talking about diagnosis, ideally, we're talking about an early diagnosis. So we want to make, is it annoying you when I turn my head around? You can still, okay. So we want to talk about an early diagnosis. Really what we want to do is, if we're unfortunate enough to be in this situation, we want to know about it, obviously, as soon as possible, so we can do as much as possible. Now, the two things that I think we are limited in within oncology with ALK lung cancer is its rarity, so its relative rareness compared to other lung cancers and other cancers, and also its newness. As I said, it's a relatively new cancer. So you have to be a little bit forgiving sometimes when within the medical world, even non-lung cancer oncologists, but certainly non-oncologists, perhaps don't know all the nitty-gritty details about different molecules, different particles associated with lung cancer. And we recognize that in oncology. So when we started seeing, in the late 2000s, when we started seeing that things were changing in cancer, this was something that we really didn't know a lot about, all the different enzymes, all the different pathways, all the different molecules. We recognized that we needed to change how we worked and how we interacted with our colleagues in the hospital. So a consultant in A&E or a GP is not going to know about ALK lung cancer. Perhaps now they should, but 2008, 2009, 2015, they may not have understood, they may not have been educated about ALK lung cancer. And it's our duty as oncologists, as lung cancer oncologists, to do that. So what we've done is, as we're discovering more and more new molecules, we're starting to communicate more with our non-oncology colleagues. How are we doing this? So there's two services that the oncologists within England, Wales, the United Kingdom have developed. In 2008, 2009 was when we realized, look, we need to act up a little bit. And we developed this service called the Acute Oncology Service. Many of you hopefully should know about this and have access to your acute oncology service. So this is where we're feeling that patients should be empowered more. They should be able to contact their oncology team if they're feeling unwell with symptoms from their cancer or from symptoms or signs of the treatment that they're taking. So that's one thing the Acute Oncology Service does. The other thing it does is it's supposed to act as a pathway and a communication method between us as the oncologists and the other non-oncologists in the hospital. So if one of my patients is in the hospital feeling unwell, the A&E doctor doesn't really know about the ALK lung cancer and what the drug is doing, they're able to then contact acute oncology, who will say, well, yes, this is what it does. I'm an oncologist, but actually I'm going to just give Sharmistha a call. I know exactly where she is, and I'm just going to get things sorted. So getting a little bit more dialogue so that the non-oncology physicians and nurses in the hospital are able to contact a specialist who knows about this lung cancer. At the same time, there are many acute oncology services who do actually offer education and training to teams such as in the A&E department, to GP services as well. So that's very important. Oh, sorry. Caught a picture of my favourite person, Lorraine Kelly, there. It was supposed to be a surprise for you. Okay. So, but going back in seriousness to the rapid access clinic. So this is another thing that the oncology team and the oncology department are doing in different NHS trusts in the country. If there are patients who have got difficult to understand symptoms, we know that ALK lung cancer, patients may not have smoked much, it may just be a light cough, quite vague symptoms, and it can be difficult to diagnose. We don't want to lose time. So what the oncologists are doing is they are having oncologists work with the diagnostic team in order to try and speed up the process and get the diagnosis done as quick as possible so that patients can then meet their oncologist with the specialist knowledge as soon as possible. So for example, if I had blood in my stools and I was concerned, I go to the GP, maybe it was a bit faint, maybe I didn't have any other symptoms, so the GP might not be quite sure. I would then go and see the gastroenterologist who investigate with a scope, and it can take a long time, and it can sometimes not be the easiest thing perhaps to diagnose, and that's when this rapid access or rapid diagnostics team, who is manned by the oncologist, come in. So they work together in trying to get the diagnosis done as quick as possible. And then ideally, patients will come through and meet the oncologist quicker, and get better outcomes and better treatment quicker. So that's all about knowledge and understanding within the medical field. I believe as well we are doing a lot, and we have a lot to do in increasing awareness and knowledge out within in the normal day-to-day environment. So out with the doctors, out with the nurses, us as a community, as human beings, every day talking about it, being aware of it, so that if somebody describes symptoms that may not be that alarming for thinking that they may have developed lung cancer, their best friend says, do you know what? I watched Lorraine Kelly this morning. There was somebody on the sofa there with very similar symptoms to yourself. Why? I don't think you're being a hypochondriac. Why don't you go and see the GP? Why don't you just go to A&E? Let's get this checked out. And feeling that they've got the energy and the courage to do that and speak up. So I think that's really important, being aware within the healthcare setting, but out with as well, and us being able to promote that for the future. So we've talked about prevention and diagnosis, and then the next thing I wanted to talk about was treatment. So two aspects of treatment. First of all, current treatment. Again, because it's relatively new and we're quite a wide geographical community in the UK, there's maybe a lack of consistency in all the different modes of treatment that patients are receiving. And this is where I think it would be good if we could come together and make sure that patients are treated evenly and equally, regardless of where you live, regardless of who your oncologist is, so that we know that we're doing the same for everybody. So again, this has been recognised within the people, the doctors and the nurses, treating our patients. And so we are doing different things like creating ALK expert groups. So perhaps if an oncologist has a patient and has an ALK patient who he or she's maybe not that familiar with, maybe there's new trials, maybe there's new treatments, maybe they're not quite sure about the side effects of a new drug because they've not had experience of prescribing that drug, they can pull in and call on the ALK expert group. Different charities as well have different events, different seminars where ask the expert kind of seminars where patients as well as other healthcare professionals can ask questions and get the experts to kind of give their views. And the expert themselves, we need to meet regularly as well, have our own meetings and make sure that actually we are all kept up to date. It's a fast moving world, the oncology world at the moment, especially in this type of oncology. So we really need to have this as the priority in making sure we're not missing anything out. So the things specifically that I think we are trying to discuss and make sure there's a general consistency is imaging. What kind of imaging, the timing of imaging, whether to image or not. And these are all questions that all of you would have, and hopefully your oncologist would be able to have answers to, and if it doesn't suit, be able to discuss with their colleagues. But you need to be able to feel that you're able to ask these questions and be able to discuss it with your oncologist. Local treatment. By that I mean local to the area, not local to your geographical area. So I think you heard before from Priyanka about radiotherapy that can be given. So if we are on a tablet and things are going well in most of the disease, there may be one area that's being a little bit resistant to the tablet. We want to use this tablet for as long as possible. We want to get every single ounce of goodness from this tablet. But there's one area that's perhaps being a little bit stubborn. And in those cases, we've even very successfully offered radiotherapy, for example, different types of radiotherapy I think you've heard about, surgery. So there's lots of different things we can do rather than just handing out a tablet and then not seeing you for a couple of months in clinic. There's other things we can do, and we need to make sure we're keeping that dialogue going. Working in a multidisciplinary team. So I'm a medical oncologist. I treat with tablets, with chemotherapy, look at the scientific data and try and apply it. I work with the clinical oncologists who treat with radiotherapy, work with surgeons, neurosurgeons, thoracic surgeons, other people within the hospital, your clinical nurse specialist, really important person. Probably you will see them more than you'll see me, the oncologist. Have an excellent, hopefully excellent rapport with them. They can really help patients in moving through the diagnosis and all the different things going on whilst they're having treatment. We also should, I think, have good access to physiotherapists, occupational therapists, people who can really help understand what cancer fatigue is, for example, and give some really important, useful tools to try and overcome these things. And at the end of the day, it comes down to experience. And as I say, keep going on about it. We're not long been doing this, but we still have a lot of experience we can share with each other, all different types of people coming together to try and get things moving. The next thing in treatment that I wanted to talk about how we're moving forward, is future treatments. So I think it's all very well. We've got these tablets now. They're fantastic. They're amazing medications, but we obviously need something more. After a length of time, we know that the cancer can develop resistance to the tablets. We try with radiotherapy, with other treatments, as we've discussed, and you have discussed this weekend, but we need to know why this resistance is happening. We need to look at the cancer. We need to work out what is going on. Why are these tablets not giving us benefit anymore? And that's where we need to go back to the science again. So trials is where we really need to move forward in. There are a few trials opening up now. It's a real shame because when COVID started 2.5 years ago, everything halted worldwide in trials and in medicine in general, but in the oncology world. Luckily, the first group of patients, the first team of where things were going to move forward was in oncology. And we are picking up again. I can see that happening. We're all meeting like this today, for example. We couldn't have done this 2 years ago. So things are changing. We're getting the acceleration on again, but that's where we really need to focus on. In order for us to understand more about what's going on when the changes occur, we might need to get a biopsy. I think that's really important because if we can get new tissue, we can compare it to what was happening before, compare and see what's changed, and then hopefully develop new medications to target that new change, and then hopefully get a long time on those medications. So a biopsy would be using a needle to get some tissue. Sometimes it can be quite difficult to access that tissue. What we're also seeing in oncology now is something called tumor heterogeneity, where there's some part of the cancer is doing one thing, well, we can see that, and then the other part is doing another thing. So what can also help is a liquid biopsy. So a simple blood test can be taken to analyze the disease, and then we can look and compare what's going on and work with that. So these are the things that's happening in the scientific world. I don't have a lot more nitty-gritty scientific detail on it, but it's happening, and it's certainly something in the next few months, even opening up in years, this is where we're going on the science side. And quality of life. This, I think, is the most important thing. Well, the most important thing is having the medications and living longer. All the old data, even very recent data, I'm calling it old, always reported on drug A versus drug B. This is how much better drug A is than drug B, which is fantastic. That's what we need. They talked about the side effects, which we need to analyze and minimize, and they talked about safety, has to be a safe medication. And then it stopped. We never went to the next part. What about the quality of life on these medications? If we're going to be on this medication for years, we need to live our life. We need to do things, we want to go back to work, we've got things we have to do, and we need to have a good quality of life. And just recently now, the trials are starting to report on quality of life. So if you've been part of a clinical trial, you may be asked to talk about your symptoms, to report your symptoms, quite long questionnaires, and they may seem boring for you to report back, but they are used. We need to know, because that's how we can change. By knowing how you're feeling is how you're not feeling, if you're not feeling good, how we can change. So this is really, really important. And the pharmaceutical companies who are making the trials and comparing and using the drugs, they're on board with this. So a few years ago, it was before COVID, maybe 4 years ago, in ovarian cancer, we were using chemotherapy to treat the cancer, and then we feel that the disease is in remission. And we were giving patients tablets to take. And I'm not joking, the tablets were this size, massive. You couldn't crush them, you couldn't break them. I don't know how patients swallowed them. And all of us, we were saying, this is great, fantastic. This is making the cancer stay away for however many years, and that's brilliant, but we need to change these tablets. And we have to tell them and ask them, and it worked. And now the tablets are tiny. They go in the ladies' handbags, and they go off and do their stuff, taking their tablets. So this is really good. We're all working on the same page to try and improve things. I've put specifically the access to a psychologist, and I should have probably put it in the basic, in the multidisciplinary team bit, but I think this is very important specifically for us as a community. Things are different now. We know we are living longer. Things are better now within the sphere of ALK lung cancer, but I think there's a lot more that can happen in that time. And I really feel strongly about having access to good help and support from a psychologist, whether it be within your clinic, whether it be in a support group, whether it be with talking and discussing. This is something I think we need to move forward for, if people want it, in the treatment of this cancer. So, my conclusions. So I think we have come far. I think we're doing very well, but I think there's a lot more we need to do. We know just started a little bit about on prevention. I think this is something we're going to be hearing a lot about and reading a lot about, and something we can really work on. We've talked about diagnosis, really encouraging dialogue in the hospital, dialogue outside the hospital. All of us, I think, can do this to try and improve things moving forward. Treatment, we've talked about how to be consistent and how we are trying to change that moving forward, and then also all the new treatments that hopefully we will have coming up. And the quality of life and the fact that we are thinking differently and we are trying to make a difference. What can we do? Keep talking. I think that's basically what I'm saying, isn't it? Keep talking. Funding. It's all very well saying, let's have a psychologist, let's have this, let's have that. It costs money. And fundraising, awareness, making people feel like, yes, they want to put some money into this, that's really going to help. I think I was doing a marathon a few years ago, and the lady sitting next to me on the bus, we were taken to, it was the Loch Ness Marathon, so we had to go from the city to the Loch. Anyway, so we were on the bus, and the lady next to me was running it for Cancer Research UK, and she wasn't very enthusiastic. She said, I don't even know if the money goes anywhere. I was like, oh my goodness, no way. Your money definitely helps. The money that you've raised today could fund a trial. It could fund the salary for a nurse specialist who could help patients. Please run the marathon, complete it, raise the money, because it does help. It goes a long way. So I think it's really important to remember that. And work together. We're all on the same side, the drug companies, patients, nurses, doctors, everybody. That's why we're all here today. I hope you don't think this is a bit of a naff slide, but I really like it. I think this, to me, makes me feel hopeful, and I think that we were back there before, and I feel like we're just getting through all those long grasses now and going there to the sun, and hopefully make things a lot better in the future. Thank you.
So we put Dr. Bejal on the spot this morning. Does anybody have any questions for Dr. Ghosh? I am sure you do. Right, okay. Have we got a microphone? Yeah, lovely.
Sorry.
As I did, you kind of question what's caused it. Going back to sort of the air pollution, do you think that, like, especially as all of us, we would have been exposed to smoking people when, you know, you're going to restaurants, you're going to your family, your aunts, your uncles, everybody smoked years ago. Could that have been a sort of contributed to some of our cancers? Or I know it's not linked to smoking, but I know might not smoke, but we have been exposed to it. So do you think that could be part of the air pollution?
It's probably in the air in general, isn't it? And when it talks about air pollution there, it's not as if you live in the countryside where there is less pollution than, you know, myself living in London, that somebody living in the countryside not develop ALK lung cancer. So it's still in the air, and it's not mutually exclusive. So there are some patients who have smoked heavily and who do still get ALK lung cancer. It's not a protective thing either. So I'm not 100% sure. We know that I suppose the main thing to take away from today is that we know that smoking doesn't necessarily cause it, but we do have now evidence to suggest that there are things within the air, for example, maybe smoking, tobacco carcinogens, or air pollution. I'm sure other things will come up in the future as well.
And also, just you said about the change of mutation in the cells. If you had, say, cells changed in your lung, would that necessarily mean that the cells would change in your bones and your brain, or anywhere else it's spread to?
So you're talking about if we're on a tablet, and then there's a mutation that causes the resistance? Yeah. Usually it does. Not always. So sometimes we see that maybe one area is changing, but the rest of the disease is very well controlled. And then we see it sometimes, more often than not, sadly, we see that the disease becomes more active in general. So it's probably that the cancer cell is getting used to the tablet, and it's clever. It's working out a way to grow and mutate despite us switching off that ALK. It's thinking of another way to grow, and that's what we're trying to now target. So we're going to that stage now. Yeah.
Thank you.
Thanks. I was just wanting to ask, for the ALK expert group, will that cover the whole of the UK?
It should do, yeah. Right. Otherwise, I'm not putting my money where my mouth is. It should be consistent for everybody in the United Kingdom to be able to access. Yeah.
Okay. Thanks.
So Scotland as well.
Yes.
Yes.
Thanks. Could you tell by the accent?
Definitely. Yeah.
One.
I could before.
Hello. One of the exciting developments in cancer care generally over the last 10, 15 years, I think, has been immunotherapy. But as many of us know, immunotherapy, particularly PD-L1 inhibitors, seem to be ineffective with ALK. Is that still the case after progression from lorlatinib when non-ALK drivers such as MET become more prominent?
Yeah, usually even, so yeah, you're right. In ALK lung cancer in general, immunotherapy hasn't been as good as we would have wanted it to be. And generally in clinic, we don't think it's a great option. However, you know, the disease is changing as we go through treatments, so it still could be an option that we could use, but probably not early on. And then the second part of your question, if, for example, there's another mutation like a MET amplification, then again, it would probably be that we would want to target that mutation. So again, the immunotherapy, that's more of a general treatment, I like to think of it. It's not so targeted. So it treats lung cancer, and ALK lung cancer is a lung cancer. But if we've found something like a MET or a different mutation, similar to what we did at the beginning by targeting the ALK, we should try and target the MET. Does that make sense? And then the immunotherapy is there, but I wouldn't use it before. It wouldn't be that good.
Yeah. Most of us here, I think, were diagnosed at stage 4. Do you know of any particular reason? Is it just purely lack of symptoms?
That could be one thing. One thing which we know that At the cell level, when that rearrangement occurs, it sets off this pathway of enzymes, and it is quite fast, fortunately. So what we see in our patients, what we're seeing clinically, how that's translating, is that the cancer is relatively, rapidly growing and changing. So it's not unusual for us to see, like you're saying in clinic, that unfortunately we've not been early enough to get it at an early stage. So it would have started off at an early stage, but we're not getting there quick enough. And that's where I think the early diagnosis, if we can do that, would be a way to get it before.
You briefly mentioned trials, but you didn't really press onto that. I wanted to ask the question, which I'm sure a lot of us want to know, about the new targeted therapy drug that's coming out, or any other treatment options that might be progressing in the future.
So there are some early phase trials. So in order for a drug to be accessible, it has to obviously go through the phases of treatment. And the early phase drugs is where we're trying to first of all work out, we know that the drug is effective. So say for example, you have ALK lung cancer and it's not now responding to lorlatinib treatment. And then we know that there's a mutation, new acquired mutation that has occurred, and we want to target that. So we know that this new drug, we called it A, targets that. We then want to work out what dose should we use, how often should we give it, and that's an early phase trial. So it's where we call our experimental treatment, and that these trials are now opening up and looking at specifically at the mutations, the new mutations that have arisen, that tells us that's why the old medications aren't working anymore.
Is that coming over to the UK soon? Because we've heard that it's coming to London.
Yeah, they will be opening. As far as I'm aware, it's not going to be opening at Guy's soon, but it will be opening towards the end of the year.
And you mentioned about mutations. What about people that haven't had mutations, that have just had resistance? I had a liquid biopsy after I progressed on alectinib, and they said to me lorlatinib was unlikely to work, but I did respond to lorlatinib. I showed no mutations, just resistance, but I still responded to lorlatinib. So would the new targeted therapy drug be an option for me going forward to see if I'd still respond?
So in answer to your question about the trial, I don't know the exact eligibility criteria, but it may be that it might list, I know it does list the mutation specifically that new drug has been made to target.
But it should also target the wild type as well, I think, as part of the
it may do, yeah. And in that case, then yes, technically yes, you would be able to look at other things as well, like fitness and things. But specifically, if you're looking at that, there wouldn't be a reason why you couldn't go on to that.
So we haven't got an exact date for it yet, then?
No, I don't have an exact date. It is opening. I've been told November, December. I don't know if Tom's in the background, whether it's opening any earlier with you at Chelsea. Same as us, okay. Just because it works as well in London, so. But also to go back to what you said as well, sorry, you mentioned it. I think that was really important what you mentioned, that you developed resistance, but it wasn't because of a mutation, and that's really important to kind of think about. So only a third of resistance is because of an actual new mutation. And it could be because, as you said, or as another gentleman mentioned, another rearrangement or another mutation that isn't within the ALK protein, or something else completely. And sometimes we see that the cancer is actually changing itself. It may not even be an ALK lung cancer. It may have changed into a different type of lung cancer. So that's important. It's only about a third of the ones that you say with the resistance. Yeah. Yes. At the moment, it would probably be to just go on to the one and not having it concomitantly. Yeah. And the ALK one. It's not something we're doing at the moment to use both here. It might change, definitely.
here.
I'll turn mine off.
I
Sorry.
am so sorry when I do that, because I know it hurts you. So I'm really sorry about that. But actually, what I wanted to let you know is we had a meeting with Nuvalent last week, and we put the question to them, well, when are you coming to the UK? Because we're all very keen. And they were saying they had hoped that it was going to be end of September time, but unfortunately regulatory processes have been longer than they were anticipating, and so they are looking at the end of the year. But I have got some good news for our northern contingent that I don't know whether you're aware, it will be going to the Christie as well. So if you live in the north, you won't have as far to travel. So they're setting up 2 trial sites initially. So, and then there is an option to go further forward. I know for Scotland, it makes no difference. Manchester is really close to London when you live in Scotland, I know, and I'm sorry. I know, it's like that in Wales as well. But at least we got 2, which is better than 1 in my book. So, and they didn't rule out the possibility of going to Scotland. So that's good news. But yes, so at the moment we're having to wait a little bit longer towards the end of the year, but they were very encouraging, and great news around, you know, supporting patients to take part. You know, they offer travel, they cover travel expenses, overnight accommodation, all sorts of, you know, support for patients, which is fantastic, because as you hear on the US site, you know, they take part in trials and it costs them an awful lot of money because they don't get support from that perspective. So yeah, so it was a very, very positive meeting. They've agreed to actually come and speak to us when they've got further news. So we will have a presentation from them. But it's like, almost definitely will be in the new year at some point when they've got when they've opened up, started running the trial, you know, a few weeks, and then come and give us an update then. Okay?
Yeah. It's probably likely as well. Usually with these things, it's unlikely to be just those 2 centres for, you know, forevermore. And it's once things start, then other centres will get involved. As I say, we've got the expert groups talking and meeting, so it's unlikely to be just those 2, isn't it, for a long time just to start up. So it should be more available for many more people and accessible.
I just wanted to ask, we've heard about trials in the US for a vaccine. Dr. Awad in particular has spent years, I think it's under development. I just wondered what your thoughts were on an ALK positive vaccine and whether you think it might be any hope for the future with that.
Can you hear me? Yeah. If we can see evidence that it works, then 100%, yeah. We need to use any avenue, anything to target, starting like the particulate matter, pollution, vaccines, tablets, immunotherapy plus something. So yeah, if we're seeing good data from that it works and it's well tolerated, then absolutely, yeah, we should pursue that.
Do you think if it was looking like it was working out in the US, would there be any possibilities that, you know, I know in the past, if it's not accessible here, it has been possible for people to sort of fly out to get access to it, or do you think we'd have to wait for it to come over here?
We need to wait for it to come here unless people wanted to go off their own, you know, on their own and access it there. But I think things are moving quickly, and I think the world of oncology in Britain is this small. The world of oncology in the world is actually not that much bigger. And we have, you know, we do collaborations not just within the United Kingdom, but across the water as well. And that study that I talked about at the beginning was patients in individuals in England and South Korea, for example. So I think we are thinking more globally. And so we would hope that if something is successful and working there, that very quickly we would be able to bring it here as well. I think we're past the days of, if we can see something, some of the medications that have been licensed and reimbursed here in England have come off very early data. And it's quite astonishing. In the past, you'd go through quite, you'd have to go through that early phase trials that we said, phase 1, 2, 3, and phase 4. And now we used crizotinib, the first tyrosine kinase inhibitor for ALK lung cancer, based on just phase 2 data. That's really early data. But because it's such good data, you can't run away from that. You have to offer it and you have to use it. So it is picking up and I think it would be difficult for us not to be part of that if we can see evidence that it works.